welcome to Talk of the Town. My name's Karen Bukes, and I welcome you to the show. Look what I got. First time, I have to be 70 years old. I get my first one, an Apple iPhone. When it goes off, I jump 10 feet, but I love it. And I can't believe it's November already. Can you? I mean, my God. Thanksgiving, and then Christmas is coming, and we start a whole brand new year. It just goes by so quickly. Right now, I want to remind everyone, J. James Auctioneers is holding an auction at Memorial Hall. The date is November 19th. Ken and I are going. It's November 19th at 6 p.m. Refreshments will be served. It's a free event, and the public is encouraged to attend. The auction house has some fabulous items. I saw them. They posted some on Facebook. And if you wish, you can go to Memorial Hall at 12 p.m. and view the items until 6 p.m. And then the auction starts at 6. As I said, Ken and I are going. That's Tuesday, November 19th. And they do an excellent job. Let's say hello to one of our sponsors, Brewster PC Solutions with Wrestling Brewster. Wrestling has a show right here on PAC TV called Wrestling with Computers. Tune in, it's very informative. And Ken and I thank Selectman Tony Provesano for coming on to the show a few weeks ago. He was an excellent guest, and I can tell he's going to be a wonderful selectman. Now, you know you can call. You can call into the show at any point during the show, 830-3971. And tonight's guest, you can ask him a question, and it's all medically related. My guest tonight has some very important health-related issues and information for you. And we will be showing you some photos, and they're quite graphic. Our guest comes with impeccable credentials and is employed in a fabulous practice right here in Plymouth. Please welcome, from Dermatology Associates of the South Shore, David Peckham.
Hi, nice to see you. Thanks for having me.
Oh, we waited too long to have you back, David.
I had a good time last time. It was great.
Yes, you were very informative, and people talked about it for a long time.
I hope so.
Yes, and you'll get... Yes,
good things, I hope.
Yes, I'm sure. And as you can tell, he has a wonderful sense of humor. First, tell us about your personal background, David.
So I live up in Quincy. I work obviously down at Dermatology Associates right here in the Pine Hills in Plymouth, but I actually live up in Quincy. I'm originally from Massachusetts, from a small little town on the North Shore of Cape Ann called Rockport. So a little town.
We lived there for a while.
That's a beautiful little place.
Yes, it is.
So I now live in Quincy. I've got two little boys. I live with my wife. We've got a little 16-month-old and a 4-year-old, so they keep us busy. I've got my gray hair highlights coming in, so keeping me on my toes. They're lots of fun.
You showed photos of them, and they are adorable.
We'll keep them.
You keep them. Now, you're a physician assistant.
Correct.
Tell us what your role in medicine is, your training, your education.
So as a certified physician assistant, I am educated to practice medicine, but we're associated with a physician. So we are categorized as advanced practice clinicians, and in that category you'll find nurse practitioners, which is a healthcare provider people are familiar with, certified nurse midwives, which is another healthcare provider people are familiar with. So nurse anesthetists are also advanced practice clinicians. So as a PA, our education is based on the medical school model. So in other words, our training, which is a master's degree program, mimics that of what you'd see in medical school. It's a condensed, intense version of what you would see in medical school. And so we have a classroom portion and then a clinical rotation portion that lasts up over a year. And so the training is very intense, and it often can be very stressful. But the role of PAs right now in medicine. Initially, when we were brought out back in the 1960s and 70s, our role was to improve access to healthcare, which is still part of our role in medicine. But we've expanded from going from just primary care to also following other physicians into specialties, such as myself in dermatology. So in areas where there is need for healthcare providers, so in rural communities, in communities where certain specialties such as dermatology, especially here down close to the Cape where there's such a huge demand, PAs and other advanced practice clinicians can kind of fill in that gap. And so as a PA, we are dependent practitioners, so we are always associated with a physician. That does not mean that the physician is right by my side. That does not mean the physician is looking over my shoulder. That means they are there as a reference for us or set up so that we can communicate with them should we have a concern, a question. And so we prescribe prescription medications here in Massachusetts, just like physicians do. We do surgical procedures. We diagnose. We interpret lab work, order x-rays, order lab work. So very similar to what physicians do, but we're always associated with the physician as a major determining factor.
That was an excellent description of what you do, but your schooling must have been intense.
It is. So
how did you get through it?
It was before children, so it certainly made life a little more focused. But it's an intense training program, and so a lot of very qualified candidates are entering PA programs now to have the lifestyle in medicine I wanted to, and to do what I wanted to do in medicine, but have the lifestyle out of it. I made the decision, instead of going to medical school, to go to PA school, because as a PA, I can find that balance where I can do what I want to do in medicine, but have a life outside of medicine as well. So I was very happy with my decision. And,
well, perhaps you made not knowingly, you made a good choice, because a lot of physicians are leaving their practice. Do you find yourself you're going to be more important?
It's right now, so certainly the role for PAs is definitely expanding, and the number of PAs has skyrocketed since 2006. The number of PAs has certainly significantly increased. So right now in the United States, there's over 90,000 PAs practicing, and each year about 5,000 to 6,000 new PAs come onto the market. The number of PA programs has also skyrocketed. Here in Massachusetts, for the longest time, there's 3 PA programs. Now there's up to 5. So Tufts University just started a new PA program. Boston University is starting one in the next year or two. Massachusetts General Hospital Institute is starting a new PA program. So that brings the number up significantly, and that's just in the last 3 to 4 years.
There must be a need. There's a great need.
There is. There absolutely is.
That's good to know. My primary, he has a PA in his office, and she's wonderful.
Yeah, no, it's
I like going to her.
Yeah, it's a rewarding profession, both personally and professionally, because, like I said before, you get to do what I want to do in medicine, and to the capacity that I feel comfortable and want to do. But I also have a life outside that I feel comfortable with as well. So being a PA is not for everyone, neither is being a physician. Right. And so I certainly tip my hat to those who choose either route for whatever reason. So
we have a dear friend, Dr. Mark, and he's a dentist. Mm-hmm. He went to Georgetown, and he thought he practiced for a long time down on the Cape, had his own office, but found that he wanted to go into teaching, so now he's at BU.
Oh, yeah, excellent.
Yeah, so he teaches. He's a professor there now, teaching dentistry.
Interesting. So that's actually, in the last year or two, I've kind of parlayed into that avenue as well. So in Boston at Massachusetts College of Pharmacy and Health Sciences University's PA program, I'll do a guest lecture in the fall for their dermatology portion of their training.
I know where that is.
Yeah, oh yeah, right on Longwood Ave, across from Harvard Medical School and behind Mass Art. And I'm taking a lot of their clerkship, their PA students on their clinical rotations down here in Plymouth. So right now I have a student spending 4 to 5 weeks with me, and I'll take about 3 to 4 students a year. So it's certainly allows me to give back to students, because I certainly, as a student, was given a lot of knowledge, and allows me to kind of pay it forward to the students.
You're the type, though. You can teach, and you have that manner about you.
I try.
You have a good sense of humor. I bet the kids love you.
I try.
The young adults. But as a disclosure, Ken and I come to your office.
Yes.
We love going there, and it's a great practice. Now, as I said, some of these photos of, well, not some, all, and they're not that many. There's 4 of them.
Yeah, 4 or 5, I think. Yeah.
Yeah, they're very graphic, but let's discuss a topic that affects millions of people, and that's skin cancer.
Yeah.
How many types of skin cancer are there, and what kinds of treatment can a patient expect?
So when we talk about skin cancer, we typically divide it into 2 groups. There's non-melanoma skin cancers and melanoma. And so non-melanoma skin cancer is the most common kind of cancer across the board. More common than breast cancer, colon cancer, lung cancer. It's the most common cancer in humans. And so over 3.5 million cases of non-melanoma skin cancer are diagnosed a year. That's a big number. So that's 1 in 2 men in a year. So over the course of someone's lifetime, 1 out of every 2 men is going to be diagnosed with a non-melanoma skin cancer, and that includes basal cell skin cancer and squamous cell skin cancer. Those are the 2 types of non-melanoma skin cancers. So 1 in every 2 men over the course of their lifetime, and 1 in every 3 women over the course of their lifetime are going to be diagnosed with a non-melanoma skin cancer. That's a big number. And then you add to that, once they've had a diagnosis of a non-melanoma skin cancer, 5 years out from that diagnosis, the chance for a woman to develop another non-melanoma skin cancer is 50%, and for men it's 70%. So certainly a big, significant.
Why?
The reason is we're living longer. So our skin, about turn of the century, we were living into our 40s, maybe 50s if we were lucky. Now, with advancements in nutrition, advancements in society, advancements in medicine, we're living longer. And our skin, don't forget, the role of our skin is to help protect our body. And so the radiation of the sun takes a toll. And radiation is something that is cumulative. It takes time to have an effect. And so the damage we do when we're in our teens and our 20s, and we're invincible and rule the world and lying out there and tanning bed, going to the prom, that damage doesn't show up until we get into our 30s or our 40s sometimes. Forget about certainly the aging aspect of it, but certainly skin cancer, which is caused by that damage of the cells of our skin caused by radiation, causes free radicals to be released, and these free radicals causes damage to the DNA. That DNA is unable to repair itself, suppresses certain genes that discourage skin cells from producing and reproducing, and so that damage then leads to a skin cancer.
So you're saying that type of radiation, not an X-ray?
Well, any radiation for that matter. So radiation is divided into wavelengths, and so when we're talking about ultraviolet radiation, which is what we're talking about when we're talking about sun exposure, there's UVA and UVB wavelengths. And so UVB wavelengths, which I think we talked about the last show, focuses on the burning of the skin. So when you're out in the sun and you get a sunburn, that's because of the UVB wavelength. When we talk about the UVA wavelength, which is a different width, that penetrates deeper into the skin. It's not going to give you a sunburn, but it is going to penetrate deeper, causes more aging, and both of them lead to more skin cancers. And UVA, given the length of its wavelength, can pass through glass, can pass through those cloudy days where you think you're not getting any sun. So a good example of how radiation can penetrate through glass is at the end of, say, summer season when you've had a display up in a store window and say it started off bright red. By the end of summer, it's this rusty orangey color. So that's all due to radiation exposure. So it's that same radiation you get day in, day out over the course of, and now we're living up into our high 70s. 70 years, that radiation takes a toll. So that's why we're seeing more and more skin cancers. Add to that the ozone layer, thinning of the ozone, more radiation is getting through. So it's a compounding of a number of factors.
Well, what does skin, okay. We're going to look at some photos
Sure,
now.
we can look at some photos, absolutely.
Jimmy?
Let's take a look and see. So when we talk about skin cancers, there's many times when patients come into our practice, up here on the screen, we can see these are considered precancerous lesions. So this is technically not a skin cancer, but we call this an actinic keratosis. And we're looking at a variety of ways this can present. So all four, you can see, look a little different, but basically this is what we catch early stages. And this is why we always encourage our patients to come in. The sooner you come in, the sooner we can have a baseline exam and catch these early changes. Now, this doesn't look like a big, black, scary mole like melanoma. This is something that's a little more subtle, and this is something that a trained clinician can pick up and manage and treat before it continues down a path to become a squamous cell skin cancer.
So that flat one.
On the top left, that flat one is a typical look for an individual actinic keratosis. So this pink, flat patch with this rough, crusty scale on top of it. And often these, if you see on the right-hand side, the cheek there, a little difficult to appreciate, but if you were to feel this, and that's why in dermatology we touch and feel our patients. We need to feel the skin. It has a very specific texture to it, this sandpapery, rough texture. Not scaly, but really sandpapery. So you can see then on the bottom left, a little more what we call hyperkeratotic, or has got this more horn-like projection. Certainly a little more concerning looking, a lesion like that, if it hadn't been looked at before, might certainly warrant a biopsy to see if it's already transitioned over to one of the non-melanoma skin cancers like squamous cell. But this is typically what we'll see for our patients starting in our 40s, this actinic damage from those sunbathing days when we didn't know better, or if we work outside or have an outdoor lifestyle, if we're a lifeguard or work in construction or landscaping. This is the type of damage we'll typically see on those sun-exposed areas, the backs of the hands, the chest, the face, the upper back, the ears. So this is stuff we'll commonly see on a majority of our patients. And so to manage this, the good news is a majority of this we can get rid of before it has a chance to progress. And so there are some topical treatments we'll use as far as medications, as well as some other techniques, including using a cold gas, some liquid nitrogen we call cryotherapy. And so we'll often use those techniques to get this sun damage to resolve.
Okay, Jimmy. Yeah, what is that?
So this little friend, this guy is a typical classic basal cell carcinoma. So basal cell skin cancer. So each of these skin cancers are named after the cell that's affected in the skin. So when the sun damage has caused enough radiation when the radiation has caused enough damage to the skin cell, this specific cell begins to multiply and multiply and multiply. And so when it presents clinically, in other words, when this little guy shows up, usually it's been there for a number of months, kind of flying under the radar. So these don't, once again, doesn't look like a big black scary mole like most people think of skin cancer. Melanoma, when we talk about that in a few moments, is scary, it's deadly, but it's less than 5% of our skin cancers.
How big is that? I know that it looks like a giant.
So this looks big on the screen, but this could be about the size of a penny. This could be about the size of a quarter even. So they can be even smaller than a penny. So these can be more subtle. This is a little more prominent and more obvious looking, but this is painless. So when we talk about what to look for with skin cancers, we certainly always talk about mold checks and what to look for when a mold changes. Remember, our skin cancers, only about 5% of our skin cancers are melanoma, the big brown scary mole that has changed. And rightly so. It gets a lot of respect because it's deadly. So in the last year, it's estimated about over 100,000 cases of melanoma will be diagnosed, and of those cases, over 10,000 are going to die of melanoma. The death rates aren't that high with squamous cell and basal cell because it doesn't metastasize. In other words, it doesn't break off and head to the lung, head to the brain, or head to the bone the same rate as a melanoma. So when it comes to the basal cells, they're painless. Sometimes they'll bleed if they're nicked shaving. Kind of looks like a wound that just won't heal. And so usually those type of skin cancers are incidental findings. So in other words, somebody comes in with a big brown scary thing they want me to look at, or a rash, and they always say, I don't have time to do a full skin check. I always try to encourage it because the bulk of the skin cancers we find, those non-melanoma skin cancers, are incidental findings. The patients didn't even know they were there because more than patients are looking for the big brown scary guy, but it's these more subtle ones are much more common, and certainly the smaller they are, the easier they are to deal with.
Oh, okay. Can we have the last group, Jimmy?
So this
Oh.
guy here is a squamous cell carcinoma. So all these skin cancers can present in a variety of different ways. So when we had that first one we showed a moment ago, that's more of a nodular type basal cell. They can be more scar looking. They can be pigmented. So they can have a variety of different ways they can look, but this is kind of classic looks. So this one, a little more ulcerated in the center. So if you were to touch it, a little more firm to the skin. And this has a little more chance to metastasize than the basal cell skin cancer. So when we see squamous cells, those are certainly also very concerning. We want to make sure we remove them.
That was there for a while then.
Potentially. So classically, these are slow growing, but a variation of these can be pretty quick growing. They can show up within a period of a month or so, sometimes even quicker than that.
Really?
So these tend not to be painful, tend to be painless. And so these guys are the ones we want to, when they're small, get them out while they're small. Because you're not going to die of basal or squamous cell skin cancer commonly. Specifically, squamous cell has a potential, certainly, to cause death if it really does have a chance to metastasize. But the bigger they are, the bigger they are to take out. And so when we manage them, we need to make sure, from a surgical standpoint, the smaller, certainly the easier. Now, when we look at this image here, this is looking at four different examples, I should say, of melanoma. So now remember, melanoma, that's the other category of skin cancers. Certainly gets a lot of respect, but it's less than 5% of our skin cancers. And this is usually what gets people coming in, big, brown, scary things that have changed. And I love it. That's what we want people to do. When in doubt, point it out is what I always tell my patients. And so this serves two purposes, this slide does. So certainly to see the variety of ways a melanoma can present, but if you look at the bottom, asymmetry. So A, B is border, C is color, and D is diameter. The A, B, C, D criteria of what we tell patients to look for when we see something changing. So asymmetry. If you look at that one on the far left where it says asymmetry, you see the big dark spot up above, and then down below the lesion doesn't look the same. So if you drew a line right down the middle there, it doesn't match up like a mirror image. So if something is asymmetrical, in other words, if you fold it in half and it doesn't match up, that's something to point out. So that's a criteria to bring to somebody's attention, whether it's your primary care or whether it's your dermatology provider. When you look over at border, we typically like to see well-defined, even borders. When you see that guy there, it kind of undulates in and out. Sometimes they'll fade off into the skin and then fade back in, and can't really see where it starts and where it stops. So a variable border like that is something to point out. So that's a good example of another melanoma there. And then color, you can see there's a variety of colors there. From this angle, you can't see very well, but very dark, certainly towards the center, and very irregular as far as its shape. But down the bottom, there's more of a pink-red section, and then the top right, certainly a variety of brown. So very, very variable color. That's certainly something that should catch somebody's attention, and that's something we certainly would encourage somebody to bring to our office. And then diameter, not as important certainly, or not as concerning as the other changes, but when we look at diameter, if a mole or a lesion is smaller than a pencil eraser, so about 6 millimeters, and acutely over a short period of time got larger than that pencil eraser, that is something to bring to our attention. So often people come in, but it's larger than a pencil eraser, but it's been that way for 10 years. It's likely okay. So any change, and people have added E to that criteria, A, B, C, D, E for evolution. So a change in any of those criteria are certainly what we encourage patients to point out.
Wow. Well, it's a dilemma. I have a question further on, but I'm going to ask it now. You know, it's very hard to see all of your body.
It is.
So I would say it's so important to go to a skin doctor or have your partner check you out.
Absolutely.
Because you can't see the middle, you know, even in a mirror.
Absolutely.
It's very difficult.
Absolutely. So we always encourage patients, so, you know, certainly over the age of 40 should be doing an annual skin check. You know, certainly at your primary care office, you should be having an annual physical exam. And certainly if you feel comfortable with their skin check, we always encourage looking between the toes and the bottoms of the feet, the buttock area, area, areas that people can't see very well. Your primary care does a very good job of doing a skin check and a very good job of managing all your other healthcare needs. So sometimes, especially if there's a family history of melanoma, because with melanoma there's a subset of that can be familial. So if there's a family history of melanoma, or if there's numerous moles on a body where, say, over 50 moles, we encourage those types of patients to be plugged in with a dermatology provider. That way there we can just focus solely on keeping an eye on these lesions, seeing if there's any trend over time of change, and if there is, having us manage it. So that's certainly something to kind of be aware of. If somebody gets diagnosed with a melanoma, we increase their frequency of their visits to every year having 2 visits. So every 6 months for a couple years at least, coming back in to be reevaluated. Once they get to that 2-year mark, we certainly encourage continuing to come in frequently, but going back to the 1-year mark is certainly something they're welcome to do. And then I always encourage my patients once a month, and the easy way to remember that is when the calendar flips. So when October becomes November, or November becomes December, that first day or week of the month, do a little skin check. So when you come out of the shower, kind of look yourself over, get used to what a baseline exam for you looks like. What are the normal moles? What do they usually look like? And then certainly areas, if you can, look at them on the back, or have a loved one take a look. And if you start to notice anything change, slow, subtle changes are usually okay. But those are things to be cautious of. Someone needs to put their phone on vibrate, I think. We're learning how to use our iPhone, huh?
Oh. Did you see me jump? Did you hear that whistle? I'm so sorry. I'm not used to this. But you know, folks, you can call 830-3971.
It's live TV. We love it. We love it.
I'm so used to my computer. You know, I've no problem.
It's a different animal.
I mean, now we got this thing. Okay.
So treating skin cancers, if they're caught early, the non-melanoma skin cancers, a majority of the time we end up doing a surgical intervention, so cutting out the skin cancer. When we're dealing with melanoma, it certainly involves an excision. And then if we see that it's metastasized or has been staged at a certain level that lymph nodes are involved, that's when we start talking about chemotherapy, potential agents, or radiation getting involved.
You do some operations in-house.
Correct. So but at our office in the Pine Hills, we do skin cancer excisions, and up until this year, we practice Mohs surgery as well, which is a skin cancer surgery where we use a microscope to excise a skin cancer, and typically on areas like the face, the ears, where we don't have a lot of skin to play with. Using a microscope to kind of do that fine work is key to leave a good potential for healing, but we don't do that in our office currently. So now we traditionally do traditional excisions, and in areas or lesions that qualify for a Mohs technique, we refer out to Mohs providers in the area.
To Jordan Hospital.
Not necessarily, but it's outpatient as well.
I will always call it Jordan Hospital.
There you go.
I'm sorry.
No.
What's one of the worst things that a cancer patient can do? I'm sure there are many.
There are. The biggest thing is pretending it's not there. Yeah. And that can be a deadly decision. And I've had personal circumstances, I've had professional circumstances, patients. I'll show you how to turn it up. So this little side button goes like that. Then it's off. There you go.
Okay. What does it say?
Wasn't me.
Slide to unlock. Okay.
Technology, it's great, huh?
Keep talking.
No, I can't do. I can't do both. Wait, what is it? One. Okay. Oh, I keep here.
There you go.
Jeez, honest to God.
So the worst thing somebody can do is pretend it's not happening.
Yeah.
And so specifically when it comes to melanoma, because the sooner you catch it, before it has a chance to metastasize, it is curable. Majority of our melanomas are curable, but they have to be caught in time. If they're not caught in time, it's a potential death sentence. So the biggest thing is pretending it's not happening. Oh, it's fine. Oh, it used to always look that way. Not likely. And if somebody's pointing it out to you, or you know it has changed, when in doubt, point it out. And so that's one of the biggest things somebody has a history of skin cancer or skin cancer can do. The other is continue to expose yourself to that radiation, whether it's because you're a golfer, whether it's because you're a boater. My biggest recommendation to all my skin cancer patients, and all my patients rather, is to be aware of the midday sun. More important than sunscreen, we've kind of dropped down on the priority scale. The biggest priority is not so much the sunscreen, but being out of that mid-peak sun exposure. So 10 to 4, some providers will say, I'll say 11 to 3, but that 10 to 4 or 11 to 3 time frame, that is not the best time to do your lawn mowing. That is not the best time to do yard work. Take the dog out for a walk. Certainly going for a round of golf that whole period of time, or being out in the boat. The winters are certainly long here in New England. The summers are short, so get out and enjoy it. But just like a cookie, it's a once-in-a-while treat, not an everyday indulgence. So that's what I try to tell my patients.
And tanning beds are a no-no.
So tanning beds are a big no-no. I like to call them radiation coffins, because at least if you're going out to the beach, you're enjoying it, you're getting the breeze, you're enjoying the air. And so certainly in those scenarios, I encourage patients to go later in the afternoon or early in the morning, or pack it up in the midday, or at least not the whole midday hour. But with a tanning booth, you are exposing yourself to radiation. It is a carcinogen, and it's been proven. And so on two fronts, there's some legislation trying to go through to change the laws, because right now, the way that tanning devices are categorized are class 1 medical device. That's the same as a tongue depressor. That's the same as paper tape.
Who put that under medical device?
That is categorized as a class 1 medical device. So there's legislation the FDA is trying to push through to recategorize it as a moderate risk device, class 2. Here in Massachusetts, they're trying to push the laws. Right now, anybody can tan under the age of 14 as long as you have your parents' consent. If you expose yourself to a tanning booth, studies have shown consistently, you increase your chance, even if it's just a few times, for developing a melanoma by 20%. If you go tanning on a somewhat regular basis under 35, you increase your chance by 75% of developing a melanoma. So they're pushing legislation. There's a bill right now down in Boston at the State House to tighten up the parameters so that if you're under 16, you cannot go tanning, even with your parents' consent. And if you are 17 or 18, you need to have, if you're 16 or 17, you need to have parents' consent. If you're 18, you're an adult. So there's legislation to try right now in the State House. They're trying to push through to change these laws.
But at 13, you can have a condom.
That's a different discussion. We might disagree on some things there.
Yes, Stephen, nobody can hear you. You're going to have to come over here.
I told him to come over here.
Stephen has a
question. Yes.
Yes, we were talking about tanning booths. What about this new spray stuff that they do?
So spray tan. So I tell my patients, if you like the look of the tan, which right now in our society here in North America, that is a desirable look, to be tan. So if you like the look of a tan, go for the spray tan. So vegetable dyes are certainly less of a carcinogen than radiation exposure. And so the spray tan technology has gotten better. The dyes are safer, and so certainly much more preferable. And you won't find Hollywood stars tanning. They might do it down in Jersey Shore, somewhere else, because not only does it prematurely age you, but it gives you skin cancer. So you'll see them doing the spray tan for that reason. The radiation, if the skin cancer doesn't scare you, you are going to be prematurely aged. So I prefer the spray tan certainly over the radiation from the
Once in my life, I tried to go tanning.
Yeah.
Once.
Yeah.
Well, I have claustrophobia.
It's scary because actually in medicine, in dermatology, we use phototherapy to our advantage. So the radiation damages some of our cells, and we use that to our advantage in some areas of medicine. Like with psoriasis, we use UVA and UVB phototherapy. And so touching on the claustrophobia, some of our patients, we actually have a UVB phototherapy booth in our office. We'll go in there, and you're surrounded by bulbs, and it can get claustrophobic.
Standing up?
This one we have is standing up.
That's good.
Yeah.
See, a Lying down was too much of a coffin.
That's why, like I said, a coffin, a radiation coffin is like what I like to call them. So when I have patients come in, whether it's for acne, a teenage patient, whether it's because of a mystery mole they're worried about, I always take a moment to talk about sun protection, no more tanning booths, and being careful to use sunscreen. So I talked about before, staying out of the midday sun's a real priority, and then certainly sunscreen. I don't want to undersell sunscreen. Very important. 30 or above we ask for the SPF number. Now you want to see the term broad spectrum, because before that wasn't on sunscreens and didn't carry a meaning. Now if you see broad spectrum, you know it protects against UVA and UVB. So you want to see broad spectrum, have it be at least a 30, and then make sure you're reapplying it every 2 hours. Just like any medication, there's a dosing, and it needs to be reapplied. So sweating or just over time, it does wear off after 2 hours.
Well, that was very good. Now, a person comes in, they're married, they're diagnosed. Do you counsel both partners in the office as to how to take care of their mole or whatever it is?
So certainly depending on the diagnosis, obviously if my patient brings their spouse in, certainly we'll address it with them. So if we're talking about a melanoma or one of the non-melanoma skin cancers, first off, is this a life-threatening situation? So certainly those are things to kind of address. If it's just a surgical intervention, certainly not as heavy of a topic, but what I do encourage them to do is to do skin checks on each other. Once a month, having somebody take a look over your back, take a look over areas that you can't see very well. Because remember, with those non-melanoma skin cancers, once you have that diagnosis, at the 5-year mark, 50% of women are going to develop another non-melanoma skin cancer. 70% of men are going to develop another non-melanoma skin cancer at that 5-year mark. Men, unfortunately, because we're outside more, just given the nature of labor law, or labor opportunities, landscapers, roofers. So certainly men increase risk compared to women.
And isn't it a fallacy? I know that people with fair skin are more susceptible, but just because you have olive skin doesn't mean that.
Absolutely. So you certainly do have a little bit more of that melanocyte, that pigment cell in your skin. But when you get a tan, that is evidence you're getting that radiation because the melanocyte's migrating over and trying to protect your skin cells. If you have a little bit more of that natural pigmentation, you are less of a risk of burning, certainly, and compared to somebody who doesn't have as dark a complexion, slightly at advantage. But certainly I have plenty of Italians, I have plenty of people of African American descent, Caribbean descent, Asian descent that have melanomas and non-melanoma skin cancers.
Absolutely. Is skin cancer screening complicated?
So that's a good question. So I have a lot of patients who will come in, and like I noted before, if it's for an acne check or a mole or just one specific spot, but I don't have time to do the full skin check. Doing a full skin check isn't some fancy machine we put you in that takes hours. Right. It's literally a clinician looking over your skin, making notations about spots, and then the procedure itself, just like any physical exam, after we're done talking, looking you over takes maybe 5 minutes. Yeah. So it's a matter of getting that baseline exam so we have something to compare things to in the future. So if I see you 2 years from now, I know, hey, 2 years ago, that spot wasn't there on your mid-back, and that looks concerning. So the procedure itself is not very complicated at all. It's literally just somebody looking you over. We had done the Spot Skin Check, which is a campaign by the American Academy of Dermatology. We did a free skin cancer screening in our office this past spring, and we had a big turnout. A lot of patients come through, and we're very surprised at just how quick it is. It's really a pretty quick procedure. Matter of after we go through typical medical questions as far as history, going over any specific spots, it's a matter of us just looking over your skin, looking between the toes, looking on the bottoms of the feet, looking at the buttock area, looking at the back, looking at areas that you can't see very well, looking at the scalp, because melanoma can show up anywhere.
Yes, that is very true. A friend of ours had it in her hair.
Yeah, and actually the retina as well.
Scalp.
So it can be on in your eye as well. So it's something.
Really?
Absolutely. So.
Oh, it can be that. I did not know.
Yep. Absolutely. So certainly.
How does that happen?
So the light also goes through your lens and causes damage there, and that melanoma can show up there.
dear.
Melanoma can also show up where there is no light exposure. So certainly not specifically light related, but there's sometimes a gene mutation, whether it's inherited or not. So that's why we can get it between our toes. That's why we can get it on the bottoms of our feet. So it doesn't necessarily have to be just those sun-exposed areas. Certainly the non-melanoma skin cancers are usually sun-related. Squamous cell, sometimes there's a virus that can lead to squamous cell skin cancer, but majority of it's UV radiation. So melanoma, though, not specifically just radiation.
Well, you taught me something brand new there
There
with
you
the
go.
eyes.
There you go.
I don't know if this is a good point to say this right now, but I'd like to acknowledge another underwriter. And he's a great underwriter, Cape Auto and Cape Service, located on Samoset and Sandwich Streets, right here in Plymouth. And just to let you know, the Jeep is not in the shop this week. So yay on that. And we talked about the tanning bed, and you talked about the laws governing. Now, Ken and I take vitamins. We take vitamin D along with other vitamins, and they really did. I thought I could cheat.
Yeah.
And I'm supposed to take 2 potassium pills a day.
Yeah.
So I said, oh, the heck with it, I'll take 1. Well, in about 2 months, I started feeling funky.
Yeah.
I started taking it again, and it perked me right back up.
Yeah. So when it comes to vitamin D specifically,
Yes.
the
stick to
potassium, I'll focus on what my specialty. So when it comes to vitamin D, we're talking supplementations. That's a big area of debate right now. It's a hot button in medicine as far as what is a normal vitamin D level, what does low vitamin D levels mean, because vitamin D can be very protective as far as prostate cancer, colon cancer, breast cancer, certainly bone health and bone diseases. Vitamin D levels are important. And so there was some debate as to, because skincare providers have been pushing so hard to stay out of the sun and using these sun protecting factors such as sunscreen and this UPF, ultraviolet protecting factor, light protective clothing, that people weren't getting enough sun exposure. And now our skin, and for people that don't know, our skin does make vitamin D. And so when the sun gets exposed to our skin, your body does produce vitamin D. So there was debate whether that was the reason why we're having all of these patients, or a number of patients with low vitamin D levels. And so that theory has kind of been debunked. And so for a while, people were kind of pushing that, getting out 20 minutes unprotected is going to be an ideal scenario. Certainly the dermatology societies have kind of frowned upon that, because that's a significant amount of radiation exposure. We know that leads to cancer. So right now, the recommendations for patients from 1 to 70 years old is about 600 international units of vitamin D. So that's what the RDA recommends. And then as you're old, over 70, up to 800 international units. And so right now, that's the standard, and that's what our recommendation is to patients: is don't go out of your way to be lying out, especially in that midday sun. That 11 to 3 or 10 to 4 hour really is off limits. If you want to get a little sun exposure in the afternoon hours, in the morning hours, certainly a safer time of day, but being out there is going to be plenty of normal vitamin D production by your skin. And then if not, supplementing with vitamins. Your diet you can supplement. So fatty fish like salmon have a lot of vitamin D. Fortified.
How about oils?
Yep, so certain oils that will have them, fish oil, supplemented orange juice and milk now are fortified with vitamin D. So in your diet and between vitamins, certainly plenty of external vitamin D can be absorbed and not putting you at the risk of developing a skin cancer and aging.
Yeah, I don't lie out anymore. If we go to the beach, it's later in the afternoon.
Good. No.
We walk.
Yep.
Ken will always wear his hat. I do like the sun on me though, and but I don't do what I used to do years ago.
Well, when we didn't know better, we didn't do better. Now you know better, you do better. So I'll tell patients exactly what you said. It's that midday hour. So if you're going to go out for the walk, because like I said before, the summers are very short here in New England, get out and enjoy it. I don't expect you to be a vampire coming out at midnight or being a nun under a cloak. So get out there, but get to the beach earlier, or go for your walk sometime in the morning and then wrap things up, or get there in the afternoon with the beach. I'll go with my kids in the afternoon or in the morning hours, wrap things up and go out for lunch or go home for lunch, or head to the beach after lunch in those afternoon hours. And on that note, certainly as far as sunscreen with kiddos, we're always cautious under 1 year old using sunscreen because they can absorb it in their skin. So we always encourage keeping them out of that sun as best you can and using physical barriers. They have that ultraviolet protective clothing that you can purchase, wide brim hats. You'll see a lot of young parents now having those tents on the beach that are also have that ultraviolet protecting fabric that prevent the radiation passing through. So the things to be cautious with kids as well.
Excellent. It's come a long way. Ken has a question.
Yes.
David, curiosity in talking about summer sun and the need to have sunscreen. What about the other 3 seasons with the change in the sun, where the sun is in the sky?
That's a good question.
Is there one more dangerous time of the year?
Well, certainly the summer months are where we have the most exposure to the sun. The days are longer, but the sun is still intense in the spring and the fall. And our 2 big months for sunburns are on the April and October time frame. The weather's still on the cool side. People forget. They pull their shirts off. They've been cooped up all winter. At the end of the summer and that springtime, they don't get their sunscreen on. Those are the 2 big times for sunburn, especially at the end of the winter where you haven't been exposed to sun, don't have any tan to protect you, and so you go right to burning. So April and then October also, weather gets cool, people forget, the sun's still pretty intense in those times of year here in the New England area. So we recommend certainly sunscreen year-round. If you're a skier, especially in the winter months, you'll notice you will get a sunburn where your goggles come up and come down if you leave them up. That radiation is reflecting off the snow coming up. So certainly if you're doing snow activities or skiing, snowboarding, we certainly year-round recommend getting some sort of daily sunscreen on the skin.
A follow-up, if I might.
Yeah.
Higher number SPFs during April and October, or the higher numbers year-round?
So certainly when it comes to the higher number, that's a good point. Not any more specific to time of year, but certainly at least to 30 year-round. They're doing away with eventually, and they'll still see some bottles of those 100 SPFs and 80 SPFs that really don't translate in the real world. In a laboratory maybe, but not in the real world. So they're phasing out anything over 50. So you'll see less of those 180 SPFs. So certainly as you get above a 30, not a huge difference. If you've got the 50, certainly put it on. But you're not going to reapply any more differently than you would the 30, which is every 2 hours. So as far as time of year, not any different compared to the summer months or spring or winter or fall. So 30 every 2 hours. And then as far as how much to put on, it's another question. If we're covering your body, about a shot glass size, about 2 big tablespoons is enough to cover the body. So a fair amount to get over the body, so don't skimp. Yeah.
Now, what about fungus? Another lovely
fungus
subject.
is always a fun topic. So when we talk about fungus, common scenarios we'll see in our office, certainly athlete's foot, so tinea pedis, ringworm, tinea corporis. So these are things that are a common fungus in the environment on our skin, but sometimes in certain times of year, certain activities can make it more prone to causing an issue. So when things get hot and sweaty in the folds of our skin, that's a nice happy home for a fungus to set up camp. And so to manage that, we certainly encourage patients to try to keep these areas dry. So when you come out of the shower, dry between the toes. The easiest way to do that is just grab a hair dryer, a quick blast on the cool setting, gets it nice and dry, making it less of a welcoming environment in that sense. Making sure if we have shoes that have been damp or moist, either get tossed and get new lining of the shoes. But there's some over-the-counter things you can find certainly at the drugstore, Lotrimin or Tinactin, products that if you think you have athlete's foot, certainly I always encourage patients to have somebody look at it before you start treating it, so that way you know what you're treating before you waste 2 months running down a path.
And it doesn't matter if you're at a luxury hotel paying $2,000 a night. wear shoes around that pool.
Yeah, pool, and then also check the mattress for bed bugs. So
Oy.
that's another concern that we'll often see when it comes to, and it's going to start you itching,
Yes.
is when traveling,
I
we get
have itchy
a lot of
skin, yeah.
patients that will be exposed to bed bugs. It's more common now. It has nothing to do with the quality of the hotel. There's some great hotels in New York that have had bed bug issues. And so I always tell my patients, when you get to a hotel, put your luggage in the bathroom where there's tile floors and walk over, pull this mattress up and look at the creases where the mattress piping is. That's what you're going to look for is little black pebbly droppings or certain the bed bugs themselves. You can see the bed bugs. They're small, but they're not microscopic. And then the other thing I'll tell patients is look on the underside, because hotels aren't stupid. They'll sometimes flip the mattress if they see evidence. So just check it, and then if you're going to go out for the day, when you come in at nighttime, flip the lights back on, because the insects are photophobic. So they'll come out at night, and then if you flip the lights on and go check, you might see them slowly working their way back to the crevices that they come in. So then if you don't see anything, you can certainly put your bags in so you don't take them home.
Okay. Now I'm itchy.
Yes, yes.
Okay. And I'm really itchy now.
Yeah, no, it'll get you going.
Now I started going for pedicures.
Yep.
And I love it.
It feels. I've never had one, but I hear they're great.
A lot of men are going.
I hear.
And you have to be, pick and choose.
Yeah.
And go to a reputable one, a clean one, and. But it's wonderful, and they can do things that I can't do. But I get so ticklish. I mean,
So it always, when it comes to manicures and pedicures, from a dermatology standpoint, I'm always cautious that the little cuticle, that little waxy part that when women do their nails like to have removed, or at the nail polish, the nail salon will remove those. That's something we certainly don't encourage. It's there for a reason. It acts like a natural caulking that kind of seals between your nail and your skin and prevents yeast from getting in there, causing little yeast irritations and causing nail fungus easily to get in there. So I always encourage, if you're going to get your nails done, don't let them peel back that little cuticle. Your nails may not look the way you want them to, as far as, I don't know if that interferes with the nail polish or what the reason or goal for removing it is. But I say leave it in place, because that's there for a reason. It's there for a reason. And this time of year, you mentioned as far as dry skin, as we get back into the winter months, the relative humidity levels are dropping. And so if you tend to have kind of dry, winter itchy skin, what I'll encourage patients to do is, in your bedroom, especially if you have forced hot air heat at your house, having a humidifier for your bedroom. So that way there, at least at nighttime, you're getting some moisture on your skin without it drying out with that forced hot air. And then when you take your shower in the morning, not that steamy hot shower that feels really good on these cold mornings, but that tends to inflame the skin, and then when you come out, really dries the skin out. So just make it on the warm side. Doesn't have to be cold shower, but a little more on the tepid side. And then as far as products to clean your skin, many times very simple is better. So things that lather, have detergent in them. If you tend to have dry skin, I try to shy away from and tend to lean towards glycerin-based products. So glycerin soap, the company Cetaphil has their Gentle Skin Cleanser, which is a very good mild product. It's a great product, but it doesn't lather, so it takes some getting used to. So I certainly encourage patients using those glycerin-based products to use.
Well, I wondered why. It took me years to figure it out, and I had a good doctor. But every time I use certain products on my hair, I would itch.
Okay, like hair product or
soaps.
Shampoos.
And the same brand of soap, and I'll tell you what it was. It was Dial.
Oh, it's harsh. Dial's harsh.
And you read the label. If it says sulfur, a lot of people are allergic to sulfur. I found out I am.
Yeah. No, absolutely.
And so I try and stay away from that.
Yeah, so Dial itself is infamous for being a very harsh on the skin, very harsh on the skin. It's a surfactant, a soap, and the role of that is to decrease the surface tension of the water, which then allows us to wash away the grease. So whether it's on your plates and your dishes or on your skin. It washes away that grease. Some of that natural oil needs to stay there for your skin to stay healthy.
But I have to tell you, on the other spectrum of that, Dove breaks me out.
Yeah, so I'm not too surprised. So many people have reactions to many products, and so certainly detergents, which might be also an issue for you, can be. So sticking with the milder products like the glycerin base, so those clear bars you'll see kind of in the end caps at the supermarket in the bins, or like I said, the Cetaphil company makes their gentle skin cleanser. Those are very good mild cleansers that aren't going to strip the oil off the skin. Then when you come out of the shower, the best thing you can do is pat the skin dry so you're still damp, and that's the best time, as long as you don't have raw skin, to get a good moisturizer on.
They say to do it when your skin
While
is
you're
wet.
damp, yep. And so I'll tell some of my patients that have very dry skin, a little dollop of mineral oil, and use that instead of moisturizer. And a little goes a long way when it comes to the oil, but that locks that moisture in the skin and prevents it from drying out as the day goes on.
Yeah, it's and the older I get, the more dry my skin is. But of course, it's those hot showers.
Well, so just tweak it down. Doesn't have to be cold, but just more on the mild side. We'll recommend.
I don't know about this. But okay, before we go, what about skin tags?
So
and
skin
is another
tags,
terminology you use.
Acrocorday is the big fancy word for skin tags. But these are just little outcroppings on the skin. Classically, we'll see them in the folded areas of the skin, on the neck, the armpits, the groin area sometimes. They're benign, a normal change. Many times it's a genetic trait. So certainly if somebody came into our office and were concerned about it and wanted it removed, that's certainly something we can do. If there's numerous skin tags, insurance doesn't like to play along with that. And so from a cosmetic standpoint, we can certainly address them. Very simple. We many times we'll kind of snip them off. You'll see products over the counter that I'm always cautious with because I'm not always sure what the active ingredients are. And certain skin types, those acids many times when in there can cause some permanent scarring on the skin. So it's something, if it bothers you, bring it to your healthcare provider or dermatology office, and many times there's a safe way that we can manage it. I always get cautious when people start taking the nail clippers and snipping away, because infections will soon take place.
Oh, absolutely. You could get a staph infection.
Yeah. So I'm always cautious with the bathroom experiments.
My mother was great at dipping the scissors and whatever into alcohol.
Yeah, alcohol can sanitize it, running it over flame, but I'm always cautious.
Yeah, go to your doctor. Go to your skin doctor. Get a good one like the South Shore.
South Shore Skin, Dermatology Associates of the South Shore. So we're right in Pine Hills.
So is the fable true that, don't get mad at me, skin tags are an indication that somebody in your family years and years ago had syphilis?
Oh gosh, no. Yeah.
Do you know?
That's the first time I've heard that.
Do you know
I haven't
somebody
heard that.
said that to me? She had a skin tag.
Oh my goodness, yeah.
And she said she looked it up. I'm not going to tell you who it was.
Yeah.
It says, she looked at it. I said, what?
Yeah, no, I can promise her that. I thought you were going to say it was cursed by somebody or a witch. Yeah, no, so not related to syphilis, which is a different scenario. So fortunately, nope.
No, what are they caused by?
So they're just a genetic trait. So they're a normal change on the skin. Sometimes we'll see a higher incidence of them with people with some metabolic disorders like diabetes. We'll see a higher incidence of it. People have other hormonal scenarios, but they're usually a normal change on the skin, a genetic trait. So, but they're benign, but annoying certainly. So if they get to be bothersome enough that they really bother someone, absolutely, we'll let them know we can manage it. Talk about insurance standpoint. But if it's a spot that really bothers somebody, try not to do the bathroom experiment. Let a trained health professional take care of it for you.
Right. Yes, and so you're located at the Pine Hills?
Yep, so we're right at 8 Market Crossing behind the market there in Pine Hills. So exit 3 right off of Route 3 in Plymouth. 508-224-3800 is our number. We are accepting new patients, and so I look forward to seeing if anybody gives us a call.
I think that your business has expanded so much.
We're busy. We are busy, absolutely.
Do you have room to expand in there?
Not as far as exam rooms, no, but certainly No is a short answer. No.
No.
So we have 5 exam rooms in our office, and
You
we
have a
utilize
pretty
them.
big place.
It's a bit, yeah. Square footage wise, it's a big place. So it's for people that haven't been to our office, it's easy on the eyes. It's a nice place to work. We have, when you walk into the office, has this Mediterranean feel about it. The doctor I work with, Dr. Marco Sastre, is Argentinian, and so we have this 8-foot fountain in the middle of our office that causes a lot of grief because you have to pee after sitting there for 5 minutes because it's a tinkling fountain.
Yeah.
But it's a beautiful space. It's a beautiful space.
It really is, and I'm so happy that I found you, and Kenny's very happy. And we will have a copy of the show for you.
Excellent.
And Kenny will drop it off, and I want to thank you so much for coming.
Well, thank you for having me again. Anytime.
Give my best to Dr. Sastre.
Oh, I shall. I shall.
Now, I want to tell you, next week, Randy Parker will be on, and author Ida K. Miller. And that'll be a great show. And thank you so much for tuning in. See you in 7.